This is episode 87 of the Rio Grande Foundation's Tipping Point, New Mexico podcast. I'm Paul Gessing. I'm president of the Rio Grande Foundation, New Mexico's free market think tank. You can find out more about the foundation at riograndefoundation.org. This and every week, we'll be talking to you about public policy issues facing New Mexico. This week, I am pleased to talk and discuss healthcare policy with Dr. Deane Waldman, a New Mexican, a former pediatric cardiologist at the University of New Mexico Hospital, former board member of the Rio Grande Foundation. So you're the first board member to be interviewed on our podcast, Deane, and you are now a senior fellow in health policy with the Texas Public Policy Foundation based in Austin, Texas. Welcome to Tipping Point, New Mexico, Deane.
My pleasure to be here.
Yeah, and we've got a long history together. We've known each other for a number of years, and you've been, as I said, involved in health policy and state think tanks for quite a long time. But before we get too deep into the policy discussion, talk about your entrance into health care as a industry and your job as a pediatric cardiologist. What did you do as a doctor, especially in that realm?
I actually have to, or I'm pleased to give you my little quickie epiphany. I became a pediatric cardiologist. Frankly, I seem to connect well with children, and I used to say that they pay me to play with children. Okay, they're very sick children. They all have heart problems, but we can fix most of them. And so I really enjoyed my life as a clinical physician. Then I became the chief, actually, of cardiology at the University of Chicago. And now I found myself, despite all of this training in clinical medicine and teaching, and I did a lot of research, I suddenly found that I was in a position where I didn't know what the hell I was doing, to be quite frank. I had no business training. I knew nothing about anything to do with management strategy and so forth. So I figured, really defensively, I went back and I got my MBA. I only did it, as I said, defensively, not expecting to, A, enjoy the study, B, learn all sorts of things that are really important for the healthcare system. And after I did that study and after I applied those tools and techniques to healthcare as a patient, the system, then I began to understand what's really wrong with the system rather than simply the symptoms of illness in the system. And for the last, 15, 20 years, I have been working, writing things and talking to people and trying to get people to accept what's really wrong with healthcare and to destroy the false narratives that we all have. So that's what I've been doing for quite a while, I think somewhat effectively.
So what is wrong with healthcare, to put it bluntly? Give me your prognosis, Dr. Waldman. One
for this
or two
patient.
problems. Yes.
Yeah. I don't know. I'm sorry to say I don't know. I can give you the whole point of what I'm doing is to get people to get beyond the symptoms. Yes, things are unaffordable, and yes, I can't find a doctor who'll care for me, or if I can find one, it takes me 4 months to get in. Average wait time in a mid-sized American city in this country is 4 months to see. That's obscene. That's just bad medicine. Anyway, but those are all symptoms. So when I studied in that book that I was just mentioning to you and to Wally, Curing the Cancer in U.S. Healthcare, healthcare has a cancer. The cancer is Washington. And as soon as you accept that reality, because I can give you evidence, obviously I have a whole book of evidence for that, once you accept that, you say, oh, well, then the cure is fairly straightforward. Get Washington out of healthcare.
So Washington is a big thing and does a lot. But what one or two areas should Washington specifically get out of? Now, I'm no healthcare expert like to the extent that you are, certainly policy expert, yes. I've always felt that the third-party payment system and the tax advantage for employers to purchase health care on behalf of their employees was the original sin of American healthcare. But
actually, that was the second sin. The original sin was when insurance ceased to be insurance and became a prepayment plan. In the 1930s, that's what happened. Prior to the 1930s, insurance for health was for lost wages and would pay part of your hospital bill after you paid it. So you paid a small amount to an insurance company and said, if I have some kind of a problem and I have a hospital bill of, in those days, $500, I'm going to pay you $2 a month, and you're going to pay me, if I have to go to the hospital, $100 or $500 or some number. And that was it. That had nothing to do with the insurance company being a decision maker between the patient and the doctor. It was when insurance plans became prepayment plans, suddenly they could make decisions about what care you got, how much the doctor got paid, when you got care, or if you got care. And that to me is the original sin.
Fair enough. So you have insurance companies getting involved directly in healthcare and decision making. The third-party payment system closely intertwined. Would you say that the third and fourth sins were Medicare and Medicaid, or what comes next? And more importantly, kind of broadly speaking here about the underpinnings of American healthcare, a lot of folks, especially on the left, talk about how Britain and Canada and other countries with these single-payer systems have better health care outcomes than we do, with government systems spending a lot less money. How do you unpack all of that? And if you want to answer the Medicare and Medicaid questions, because those are definitely moving us. People say, "Oh, we're a free market capitalist health system." Well, that could not be further from the truth. But talk just about these comparisons.
Let's start with it works in Great Britain and it works in Canada, and it costs less, so why don't we just adopt their systems? Well, let's look at that a little more carefully before we jump out of the frying pan into the fire, and that is, number one, they are cheaper by medical rationing. Americans, are you willing to accept the fact? I had two mothers. One was American, one was British. My British mother, at the age of 78, fell down and broke her hip. And the National Health Service said, yes, you've only paid in for like 60 years into our system, and you're a taxpayer. So, yes, we approve your hip replacement. And they scheduled her surgery for 27 months in the future. Well, any doctor who actually graduated medical school will tell you take a 78-year-old lady and put her in bed immobile, unable to move. Two things happen. One, she's going to die of an infection, pulmonary embolus, whatever. And number two, you're going to pay a lot of money for nursing care in her home or in a facility, whichever one you want to look at. So they expected her to die before they had to pay for the operation. If you want something a little closer to home, you should read about two babies named Charlie Gard and Alfie Evans, both of whom were on ventilators, and the government said, time to take them off, against the wishes of the parents. They took them off the ventilators and the babies died. Well, I'm sorry, that's immoral. The only person who should make a decision about life and death, or for that matter, surgery, not surgery, take drugs, whatever, is either the patient himself or somebody in as guardian. And in the case of my case, it's the parents. But whichever. So my point is, the single-payer systems, back to answering your question, the single-payer systems save money by rationing care. When you look at them, yes, they're cheaper, but I don't know how dollar efficient they are. And that's a piece of data that I want for us and I want for them. Dollar efficiency is defined as very simple. Dollar efficiency is the amount of money that goes into a system, an organization, a commercial business, whatever. The amount of money that goes into that system that comes out as value to the consumer. So if you make cars, all the money that goes to what the consumers perceive as value, longer lasting tires or higher resale value, whatever, if that money contributes to that, it is dollar efficient. If it doesn't contribute to value addition, it is not dollar efficient. What do we want from the healthcare system? The answer is very simple. We want a healthy people, but it's a little hard to measure that. And B, we want access to care. So to the extent that dollars contribute to getting access to care, they are dollar efficient. If the dollars don't go to patient care in some form, they are inefficient. How do we do as a country? Answer, and we're going to get to Medicaid in just 1 second. How do we do as a nation? Answer, studies I've done, studies that Steffi Woolhandler from Harvard have done, and these were before Obamacare, suggested that around 40% of all healthcare spending produces no care. Now that means it's only 60% dollar efficient, or to put it another way, that's $1 trillion that goes to the federal bureaucracy, whether it's regulatory or administrative, goes to the federal bureaucracy that we doctors cannot use to provide care for patients. And that makes me crazy.
Now, before we get on to those government programs like Medicaid,
yes,
have you or has anyone studied the differences between, Canada and England, and whether the U.S. gets more? And I tend to agree with you that how much care you get is a good thing. Obviously, there are cases of unnecessary care in the United States and potentially other countries. Obviously more familiar with the U.S. system. So it's not that rationing is the right solution, but empowering patients with the knowledge based on pricing in a relatively free healthcare market, they can make the decision clear for whether they're getting every single treatment they could or could not. So I asked you a lot.
Well, let me hone down for a moment on the word ration. Ration means to make reasonable, and in the economic sense, it means to balance supply and demand. It's that simple. Somebody has to balance supply and demand, whether it's in the automotive industry or in healthcare, whatever it is, somebody has to. Now, in our country, in the vast majority of cases, the free market balances supply and demand. Price goes up, price goes down, depending on supply and whether the consumers want it or not, whatever it is. In healthcare, they are disconnected by the third-party payer, and therefore, the rationing, the thing that balances supply and demand, is central economic control, also known as the Soviet Union, also known as the way that single payers ration care. And what I want, frankly, as both a patient and a physician, I want the patient to ration his or her care. He's the one who should be deciding on spending the money and whether the service they're going to get is worth it. And if you want to have a hernia repair and one doctor says, sure, I can do it and here are my results and I can schedule you 3 years from now, and another doctor says, well, here are my results, here's my price, and I can schedule you the next week, then the patient makes the decision based on those things. He or she is rationing her care, and that's the way the system should be. In a free market, that's the way you get the most goods and services at the highest level of quality at the lowest price, is by free market.
Is that, well, let's get back to those other countries. Did you say you have some information about how much those other countries, how much of their money gets into
yes, and the answer
surgery
is
and
no. I have actually tried very hard to get the answer to that question by studying all sorts of materials. I will tell you that I can't speak for the Canadians, but British authors who have done the same thing I have done have said the system is intentionally opaque.
And I've heard that it is not always as easy as these international comparisons purport to make it.
That's
as
true.
simple as
Yep.
these direct dollar comparisons. One of them that I understand is the taxpayers of many of these foreign countries pay for medical school, schooling all the way up until medical school directly, which if you're an American doctor, you are paying for that amortized over decades of, charging people a high enough price on their health care to actually make up for potentially $100,000+ in medical school debt.
One of the reasons that we have, and we're trying to back out of it, and I'll tell you about that actually in Texas. One of the reasons we have too many, well, I shouldn't say too many. One of the reasons we have too few primary care doctors is because a lot of people go into specialties. Part of the reason they go into specialties is the average American medical student graduates, this is 2016 data, I think, graduates medical school with $184,000 worth of student loans. Well, how the heck are you going to pay that off as a primary care doctor when you're barely making ends meet and you're sitting with this nut of $184,000 to pay off? On the other hand, specialists get paid more and you're more likely to pay off your loans. So that's a huge problem. And I'll get right to it since I promised you I would. In Texas, one of the things that they are doing, and as a matter of fact, in the current legislature where I'm advocating, as are others, to expand the program, is a loan forgiveness program for those who, A, do primary care, and B, go to rural or underserved areas. And so it's a little like a strange form of a berry plan. You graduate medical school, you want to be a primary care doctor. I mean, there's a lot of wonderful psychic feedback, a psychic reward of being the only doctor in a town of 10,000 or 15,000. You're part of the community. Everybody knows you. You know everybody. That's really a very attractive. But how the heck can you do that with $184,000? On the other hand, if you have a loan forgiveness program in return for, I'm making it up, 5 years of service in an underserved area, in some kind of a declining scale, will pay off your loan. We, the town, will pay off your loan. Sounds like a good deal to me. So my point is, the economics in our country is a very real driving factor away from what we need, which is primary care.
All right, so we've kind of talked about the underpinnings going back to the 30s of American healthcare and why it's challenged some of the difficulties of international comparisons. Of course, there's Obamacare. I don't want to dwell on Obamacare, but could you kind of summarize what you believe Obamacare did for American healthcare in a sentence or two?
I would change that answer to say what I know, what the evidence shows that Obamacare did, not what I believe.
Fair enough.
The data is very clear. The affordable, I put quotes around the word affordable, act more than doubled the cost of health insurance in our country. So what was unaffordable before, and sorry for my bad grammar, is now more unaffordable. I know that's not.
We get the picture. It's okay. You went to you have an MBA and you were a pediatric cardiologist.
So
we'll avoid the verbal jiu-jitsu, but
thank you. But wait a minute. The second part is more important,
right? Which
is we gave insurance. We, the country, gave free insurance. Depending on whose numbers you read, between 80 and 95% of all the newly insured people in our country got their insurance through free, that is no charge, Medicaid expansion. That's where the vast majority of newly insured came. So what happened? We gave, depending on whose numbers, 16.7 to as high as 19 million newly insured Americans. And in order to pay for that, we reduced reimbursement schedules in Medicaid. And that's New Mexico, unfortunately, is a perfect example of it. In 2017, New Mexico gained $3 billion in new money for Medicaid expansion, and the cost of the insurance benefits, not the cost of care, the cost to the state of New Mexico for the mandated insurance benefits on paper was 3.417. That is $417 million. This is in the Albuquerque Journal. $417 million more than the amount of money we got from the federal government. What did the state Medicaid program do? Because it had to. It has to have a balanced budget. We can't print money. They cut reimbursements schedules to doctors, which made doctors less available at the same time as we increased the number of insured people. So they got insurance that didn't lead to care.
Now, let's take a quick note. Medicaid, of course, is the government health care program administered by the federal government through the states for typically low-income people, although it's got a big component for elderly and long-term care. Secondly, you continue to reside in New Mexico, although you commute to Austin, Texas, 3 days or 4 days a week for your work. So you are yet another New Mexican finding work in a more economically prosperous state. Happens to be Texas, of course. And third, New Mexico was a state that enthusiastically, I think would be an appropriate way to describe it, adopted Medicaid expansion and has been busy under a bipartisan series of administrations here now, Martinez now and Lujan Grisham, putting as many people onto the Medicaid rolls as possible, whereas Texas did not embrace Medicaid expansion. So
all correct.
Take any of that and go with it as you see fit.
Texas has, I actually wrote this article that I would wish people would read, everybody would read, although it got a lot of press. What I did was I looked at the states with the highest number of uninsured, Texas being number one, and the lowest number of uninsured, which actually is New York State, but New Mexico is down there in terms of low numbers of uninsured. 42% of the state of New Mexico population is on Medicaid. That's almost half of the state.
So when you say uninsured, you're talking post-Obamacare in counting Medicaid as insurance.
Correct.
Okay.
That's very important that you make that clarification, because that's right. I'm talking about those people without insurance. Now, it turns out that Medicaid doesn't lead to care, but that's not what we're talking about. So what I did was I simply said, okay, let's compare New York, which has the lowest uninsured rate, with Texas, which has the highest uninsured rate. How do they do for access to primary care? And the answer is, by a whole bunch of statistics, New York satisfies 40 to 45% of the primary care needs of its people, and Texas, with the highest uninsured rate, satisfies 70% of its. So in a sense, if you just looked at those numbers, you'd say, okay, then what we want is more uninsured people because more people get care. Well, the answer is very simple. The doctors in Texas are more available to their people, to Texans, than the doctors are here in New Mexico because of the Medicaid reimbursement schedule.
And there have been studies that I've seen that say that being on Medicaid actually results in worse health care outcomes than uninsured.
There are a number of studies that have shown people, for example, one in Illinois by Nick Horton, showing that I think his number was 752 people in Illinois died waiting in line for care on Medicaid because they couldn't get timely care. So yes, they have, quote, coverage on a piece of paper, but no, they don't get the care. And by the way, I should say up front, we talked earlier, and I don't want to lose this thing. We have a single payer in this country. We have a large single payer system in this country. It's called the VA. And an internal audit in the VA in 2015 said, and I quote, I'm now quoting their own audit, 307,000 U.S. veterans may have died waiting for care in the VA system. So what we call death by queuing is a very real factor in single payers and is obviously a very real factor in Medicaid. And so when, and we can get right, because you asked me, you wanted to talk about buying into Medicaid here in the state of New Mexico. Why in heaven's name would you want to buy into a program that doesn't get you the care you need when you need it?
Yeah, this is legislation. It was introduced in a serious context this session. The Democrats, majorities in both houses, said they wanted to give people who don't qualify financially for Medicaid, even though New Mexico already has pretty generous Medicaid rules and financial requirements in terms of income levels, that allow them to buy into Medicaid. So that's what Dr. Deane is referring to. And I'm sure Dr. Deane is also aware of the Albuquerque Journal's reporting where they've found that New Mexico is among the U.S. states, to your point about physician reimbursements under Medicaid, that we have an aging and limited pool of doctors. And what it sounds like to me, and again, you can correct me if I'm wrong, that Texas, while it has rejected Medicaid, it has Medicaid expansion, I should say, not the entire program. The uninsured people in Texas who are uninsured at a higher rate than in a lot of other states, in all other states, that they've got enough doctors there to pick up the slack and actually service people, whereas New Mexico is on the other end. Everybody's in Medicaid, so to speak, and doctors are not coming here.
No need to correct you. You're dead on.
All right. Well, there we go. So that is Medicaid, and it is a very expensive program. It is among, they didn't get a true single payer out of Obamacare, so they're working piecemeal, the left and its advocates, to expand each proportion of government health care, including Medicaid, to do what they can with this patchwork system to make it resemble as much Canada or Britain or other nations.
So you're leading to Medicare for all.
Medicare for all, yes.
Thank you. You had to get to that sooner or later.
Yes.
Okay.
I'm sure you're a big fan, Dr. Deane Waldman. I'm kidding, of course. Medicare for all, of course, this is the program for the aged explicitly. Again, Medicaid, long-term care, actually the fastest growing area of Medicaid. It's a lot more expensive to treat end-of-life issues and in the elderly than to put women and small children on a healthcare program. But that's kind of neither here nor there. It's just worth understanding the facts. But Medicare for all is the next big scheme. All the Democrats almost running for president seem to be behind this. It just scares the living daylights out of, I think, anyone who sees the real issues here. But talk about what they're really up to here.
Before I answer that question, you have to put in one other thing that is so obvious that most people don't think about it, and that is Medicare was supposed to provide for your medical needs after you retire for the elderly, okay? What's the one thing that is exclusive to the elderly, essentially? Nursing homes. So what is it? The one thing that Medicare doesn't cover: nursing care, elder care. That's why what you said earlier is quite correct. Medicaid has to pick up the slack for our elder care because Medicare, what should be covering it, doesn't cover it. All right, Medicare for all, let's just face it. Medicare for all is Medicaid for all. They package it with a name that people tend to trust. whereas they don't trust Medicaid. But in point of fact, Medicaid is a government-run program that is no charge to the people who enroll in it. What they're proposing for Medicare for all is exactly the same thing, which is they take taxes. You don't have to pay for anything. There's no charge to you as a patient, and you're enrolled in a government program. Now, there are a few problems with their program, and we'll get to the big issues in a second. But how about the fact that it eliminates all private insurance? So 180 some million Americans will lose private insurance, most of whom like the program that they're already on, and now they have to, by law, accept the government program. Number two, the Medicare for All bill, which is H.R. 1384, that's what Bernie Sanders has been talking about, and the actual author is a lady named Jayapal from, I think, the state of Washington, a Democrat, explicitly rejects the profit motive. It says we reject and will suppress the profit motive. Well, excuse me, the profit motive is the basis, not the sole basis, of capitalism. And we happen to think that capitalism is a good thing. It's the best way to get the most goods and services at the lowest price. So why would you reject the profit motive? Because they want to control everything. Number three, there is a section, I think it's 102, entitled Universal Entitlement, which means everybody is entitled to this program. Whether you're legal or illegal, you're entitled to this program, period. All you do is put your name down, sign up, and you're in this program. Well, excuse me, that means the government is responsible for you, which denies personal responsibility. And what's the essence of what we would call autonomy or individual freedom is what comes with individual freedom is personal responsibility. That is the foundation of this nation. And now their Medicare for All wants to eliminate personal responsibility, eliminate private insurance, eliminate the profit motive and therefore all forms of capitalism, and take over your life. And I have such negative feelings about this that it's hard for me to speak without a great deal of passion in my voice. So let me give you as a final sort of, there are 5 reasons why I have been a vehement opponent of Medicare for all, whatever you call it. Number 1, historical. Government has been trying to, forgive the phrase, fix healthcare for the last 50-odd years, starting with Medicare and Medicaid in 1965. The result of their fixes is where we are now. Why in heaven's name should we trust them to suddenly fix it with another plan and make it work for us, we the people, when they have failed for the last 50-odd years? Number 2, there is the practical that we've already talked about, which means the government will ration your care. They will decide what care you get. The National Health Service in Great Britain, over the age of 55, and I now quote their manual, kidney dialysis is, quote, not cost effective, end quote. Therefore, if you're a 56-year-old man or woman, but it's usually men, in Great Britain and you're in kidney failure, the National Health Service says, sorry, go die. And that's just immoral. And it's the only word I would use. Number 3, you got the fiscal. Let's talk about the fact that the best estimate on the cost of Bernie Sanders' plan is $32 trillion, 32.6 to be exact, over 10 years, which is, if you just do the math, $3.2 trillion a year. Last year, we spent $3.5 trillion. That's additional.
Total.
So what would happen is we would then be spending almost $7 trillion a year. That's 30% of our GDP, by the way.
And Medicare is already seriously underfunded.
I'm glad you brought that up. That's exactly right. Medicare, that's another point, and it's a really important one. Thank you. Medicare by the CBO's estimate, will be broke in 2029 or sooner. Therefore, in 2029, all us old people, and I include myself because I am, will not get care from Medicare because there'll be no money. So that's the way the government handled, accounted for, and dealt with the Medicare trust. Why, again, in heaven's name, would you want them to take care of all of our money when they did such a poor job with the 50 million people who are in Medicare? And let me just give you the final one, the big one, which is healthcare under federal control is unconstitutional. And it sounds like I'm a crazy conspiracy theorist. I urge anybody who's listening to this to reread the 10th Amendment to the Constitution, which says those powers not delegated to the United States, and the United States in those days meant the federal government, are reserved to the states or to the people respectively. In other words, the Constitution says if we say it belongs in the federal wheelhouse, then it does belong in the federal wheelhouse. If we don't say that it's part of the powers delegated to the federal government, then they shouldn't be involved in it. And yet, healthcare is not delegated to the federal government, and the federal government is in control of healthcare.
All right. There's one question I have, and folks who know the Rio Grande Foundation know your host understand that he is not eligible for Medicare. So I pardon my ignorance, but a lot of folks who are in the Medicare system as it currently exists buy supplemental health policies, essentially. I don't know exactly how you describe them, but they are a form of insurance to cover the things that Medicare does not necessarily cover.
You're correct. Absolutely right.
This would be, on its face, eliminated because you just said that they would be banning private
insurance,
health insurance. What do those policies currently cover, and what would it mean just hypothetically if we wound up in this nightmare scenario, Medicare for all?
And what it would mean is that services that the federal government thinks are too expensive for me, I'm almost 76 years old, it, quote, not cost-effective care, I don't get it. Just that simple. Can't get it.
And that you mentioned dialysis earlier.
Sure, that's a good example.
What other kinds of
heart surgery over the again, Great Britain, heart surgery over the age of 65. Second hip replacement. I have a good friend I race bicycles, and he also races bicycles. He's actually broken one hip twice, including the replaced hip. So if the federal government were in charge, second hip replacement, nope, too bad. You're now immobile. You're going to remain in pain forever. That's just the way. I could go on and on. It's
sure.
There are a whole. If it's cheap, cancer treatment. Some of the cancer treatments. We didn't bring this up, and I think I really need to. One of the reasons why healthcare has gotten so expensive compared to my grandfather's day is because the value that healthcare can deliver to the patients. Everything I did as a professional physician for 40 years was impossible in my grandfather's day. So all the babies that I took care of in my grandfather's day died. Every patient with cancer, including my father, died. Okay? Now, I wouldn't say all, but a childhood leukemia, it made me sick when I was in training to watch all these beautiful little babies come in with all sorts of problems, and they had leukemia at the core, and they all died. When I was in medical school, they all died. Okay, now the success rate, depending on the cell type, ranges between as low as 72% and as high as 95% of children with leukemia are cured. Okay, that costs money. Does that mean we should stop? If we want to save money, we should stop saving children with leukemia? Quite the opposite. This is great value that the medical world has provided to patients. And I just want to get it out there that when we keep talking about saving money, well, then let's not treat anybody with breast cancer, colon cancer, childhood leukemia. No, don't treat them. It's expensive. Let's save money. Well, excuse me, the purpose of the system is to make people well, not to save money. So I'm sorry, but I had to get...
that is all very good, and I think it's important to share some of the success stories we've seen in American healthcare. And part of the problem is that we've been successful in prolonging human life, and there are costs associated with doing that and continuing to do it.
I've got to, again, forgive me, interrupt you. It's not just prolonging human life, because one of the things improving, that's right. One of the things that we get dinged on in the United States is our Japan has a longer longevity of their people than we do, a lower infant mortality than we do. When you start looking a lower obesity rate, diabetes and so forth, when you start looking at those national population, I should say, statistics about health, any doctor will tell you, they are much more related to lifestyle, diet, and genetics than they are to anything that I do as a physician or any physician does. So I don't like that argument. Well, look at, Japan does it for $1 trillion. I don't know what the number is. $1 trillion less than we do, and they live longer. Well, yeah, they live longer because they exercise, because their diets are better, because they have a lower incidence of illicit drugs, etc. And their culture, quite frankly, respects the elders rather than shoves them into nursing homes.
They don't drive as much. They certainly don't get shot as much. We know that in Albuquerque in the last few weeks, we've seen more than our fair share of those kinds of issues as well. And, so let's talk solutions. And I'm really at this point, unfortunately, where I would normally talk about state level solutions. New Mexico is nowhere near the racetrack in terms of leading or adopting some of the better healthcare policies out there. And really, this is a discussion that has to be led at the federal level. Realistically speaking, I know we can talk about our fantasy of how healthcare could or should work with a relatively free market, but where could Donald Trump and the Congress go right now with healthcare in a realistic way that actually will improve things?
I don't think, I'll tell you where they could, but I don't think there's a hope in that they will. And the reason I say that is that the solution is deregulation. The solution is devolving the levers of power down to the state level, so that, and I like saying this over and over, even though I think they're wrong. If California, 39 million people, want a single-payer system, I say, I have data. I wrote a whole book entitled Single Payer Won't Save Us. But if they want to do that, why should Washington, or for that matter, Deane Waldman, tell them not to do it?
Well, if they're willing to pay for it themselves, and that's the ultimate problem here.
And I'm sorry, but that's right. That's supposed to. If right. Texas wants a market-based system, which we do, why should Washington make us do California's approach or Washington's approach or whoever? So the long answer is, to the extent, the short answer, which is also the long answer, to the extent that the president can encourage or force or whatever the deregulation, the withdrawal of federal mandates from controlling healthcare in all the one size fits all. I mean, the thought that to the extent that he can do that is good. And I will tell you right now, CMS, which is the Centers for Medicare and Medicaid Services, is working very hard and bit by bit is trying to get more power down to the state level and not have these federal mandates where it's the same thing in Rhode Island as it is in Wyoming. I mean, it makes absolutely no sense that you have the same system in those two places.
You got it. So states should be empowered to address healthcare, but also should be on the hook for paying for it. None of this shell game, shifting money around, which unfortunately here in New Mexico, the motto is, how much can we get out of the other states? And that was, again, present in the recent legislative session that just concluded. I'm sorry we could sit here and talk healthcare and healthcare policy all day long, but between the Texas Public Policy Foundation and your books, how can people read more of your material, Dr. Deane?
I urge people to read this book that I just put out called Curing the Cancer in U.S. Healthcare. They can always go to my website and both get the book and get prior books and get articles and stuff like that. And my website is real hard to remember. It's my name, DeaneWaldman.com. But my mother, 75 years ago, put an E on the end of Deane, and I've been paying for that ever since. So my name is Deane Waldman.com, WALDMAN. And everybody, even occasionally my mother, spelled it wrong. So that's why I warn people about it. I have everybody who has read that book, Curing the Cancer in U.S. Healthcare, has come away saying, well, sure, that's what we should do. And the only problem with my solution is that it requires the people to say to Congress, get out of my hair.
And you're also at the Texas Public Policy Foundation. That's texaspolicy.org.
That's
correct. They've got a lot of different analysts doing a lot of different work.
You got that right.
Just check out Deane Waldman, and you will get to the right place if you go there. Or I suspect in Google there's not too many folks with your name, and certainly not the doctor in front of it. Thanks for listening to this week's discussion. We're working every day to turn New Mexico around. Go to RioGrandeFoundation.org for more information or to support our work.